talked about minute ventilation and alveolar ventilation, and we have to increase both in the case of a respiratory acidosis, correct? There are some very lovely formulas that will help us figure out what to do. I listed them here again as well. So alveolar ventilation varies from normal minute ventilation, the fact that it takes into account dead space, okay? And the formula's there. Normal alveolar ventilation is 4 to 5 liters a minute, whereas a normal minute ventilation is 5 to 8 liters a minute. So you take in a lot more gas than is actually being used due to dead space. So if I'm looking at a patient who has a respiratory acidosis, I have to figure out a way to increase that alveolar minute ventilation. And we talked about this in the way of blood gases. So this is off of your blood gas cheat sheet. You have it. Is it that?
Yeah, I mean, I'm not great, but it's better than that one.
I'm sorry, those cookies are making me crazy. Okay, so in the order to fix that, okay, we talked about our 4 life functions. So we fix ventilation always first. So ventilation is just kind of a blanket. We need to think about specifically what kind of ventilation we're going to correct first. We always have to fix a respiratory acidosis. That is the number 1 thing to fix. Okay, and I treat it by going up on my minute ventilation or alveolar ventilation, and I can do that by increasing VT or increasing the rate, right? Or I can get rid of dead space. Absolutely fabulous easy way to get rid of that if I can get rid of the dead space. Second thing I'm going to look at, and the second order of things to fix, is oxygenation, but specifically a low PO2. I never pick 2/1. Never. 2 is really common. In fact, in the hospitals, what we're doing all the time is put people on O's. But we are not doing this in place of this. Does that make sense? You have to do number 1 first. Okay. 3 is oxygenation as well, but it has to do with high PaO2 in COPD patients. And then this actually becomes number 1. Okay, so we always fix high PaO2, but in the case of COPD, it becomes the number 1 problem. Okay. Number 4, I fix ventilation issues that are related to respiratory alkalosis. But I have to figure out what the cause is. So, right, so my cause is going to be things like increased temp, low PaO2, fever, pain. Step on my foot, no, you don't that, okay? I treat it by increasing minute ventilation or alveolar ventilation. So again, I have to come down. Okay, so when I need to fix the respiratory alkalosis, I do it exactly opposite of the way I do it to fix a respiratory acidosis. So respiratory acidosis, I'm going to come up on tidal volume first to my VT range appropriate for that patient base. So whether it's asthma, COPD, asthma or ARDS, right? COVID or normal. Okay, I have to go to that rate. So I want to go as high as I can because I want to get the most breath into you that I can. And if that doesn't work, then I'm going to take my rate between 12 to 20. If they're both maxed, as Leah just told us, I can safely go above 20 if I have to. And most of the patients you're gonna see at the bedside are gonna be doing exactly that, okay? So when I come down exactly the opposite. If I've got too much ventilation that's happening and it's not because of any of these things, I can fix that by coming down on the rate first until I get somewhere lower than 20, probably closer to 12. Then I'm gonna bring down the tidal line. Does that make sense? So you really have to break it down subtly. And Dr. O likes to talk about ventilation, oxygenation, circulation, and perfusion. And we're gonna get to the circulation and perfusion stuff, okay? But for making corrections and how to approach your blood gases, you need to break it down like this. Does that make sense? Any questions? Brian, you have questions?
No, I'm just really trying to get
Okay,
on
you
my head.
take grab that. So yeah, so again, I fixed high PO2 third, but in the case of COPD, that becomes my number one problem. Okay, because if I have high PO2 and a respiratory acidosis happening, I've caused it. That becomes the number one issue. Okay? Yeah, find my little thingies in my clicker. So how we're going to fix either minute ventilation or alveolar ventilation is what I just said. We're going to go up on the tidal volume as appropriate. But if for some crazy reason you were starting out at a tidal volume at a rate less than 10. Let's say for some reason some person was being weaned and they had an SIMV rate happening of 6. Okay? I would actually turn it up first because I'm not even efficiently ventilating them. Maybe the nurse gave them drugs and now they're just breathing 6 a minute. Common sense should tell you you're going to fix that. Okay? Increase my rate. If it's set below 10, that's duh. If tidal volume is my issue, I can always go up. Now, I want you to hear me when I say this. Dr. O is very specific about 6 to 8 mLs per kilo normal mechanical tidal volume range. Okay? I'm going to tell you, the boards are going to let you go to 10. Okay? I was just doing some practice ones with a student, and I picked the one that had 10 mLs per kilo, and we were doing just fine. Okay? So just to put that in your wheelhouse. The boards have told him specifically 6 to 8, but I've seen lots of practice ones that let you take it clear to 10. So don't worry if you have to use a volume that's a little bigger. Well, let's say I'm ventilating too much. Well, also easy fix, and that's what's number 4 over there. I can decrease the rate, right, unless I'm already less than 10, because 10 is not safe. Or I can decrease the tidal volume. So when I come down on the rate first, until I get somewhere more manageable, and then I'm going to go ahead and come down on the tidal volume. You don't want to come down on tidal volume first because you do not want to de-recruit. And low tidal volumes de-recruit lungs. So if I'm taking the tidal volume down, this statement is really important. I don't want to come down to less than 6 mLs per kilo. That's not safe for normal lungs. Okay? Asthma and ARDS, all that drop. So when you think about this as a patient, patient-based, it's not just somebody in the bed with numbers. Yes, it is somebody in the bed with numbers, but I need to think about what I'm doing to them, and real people are much harder to tweak than the patients you're going to get on your board exam. And some of you guys have seen that. Those of you who've shadowed or come with me, we have lots of patients who would not have tolerated a decrease in set rate, right? Or you gave them their adequate tidal volume according to what we should set, and they went absolutely bananas and hated life, right? So real people are going to be a little bit different. Hey, Kelly. Good morning. How are you?
Good, how are you?
Good. I'm going to get my life in order. Oh, thank you.
Story of my life.
Okay, see, now I have lunch. There was a joke that came right to bring them candy bars, and I'm like, I'm so hungry, I haven't eaten all day. She walked right by me. Oh, let me give you a hug. Thank you.
Of course.
Thank you very much. I appreciate you.
Of course.
Take care of yourself. That's it.
I'm like, it's break finally, so.
It's what?
Break.
I know, are you excited?
Very.
You gonna work too much? You probably work too much, though.
I start Loveless Monday. Finally.
As what?
A tech.
Oh, cool.
But, I was communicated and said, I graduated in a month, so the transition and, okay, we need help now.
Oh, yeah, they need help now. There's been a cry for help every single day to my phone.
I believe it.
Yeah, they're desperate. Thank you. See you at Loveless.
Do you know if Holly's still here?
She's next door.
Okay, perfect.
All right, guys. Anyway, so what I have to to teach you to get past your boards is that methodology. So you're gonna follow that to the letter, okay? But your common sense should tell you that real people may or may not respond to this on a real patient, okay? So you're gonna do that on the boards all day. And for all my tests, follow that methodology. But just, you may have to alter something when you're dealing with a real person who's on the other side of that vent, okay? But you can assume that dead space and CO2 production will remain constant when adjusting ventilation in a clinical setting, which means if I turn up the rate, I should blow off CO2. If I turn up the tidal volume, I should blow off CO2, right? And the way the world should work, that's what's supposed to happen. So tidal volume and rate are adjusted to control things in volume controlled modes, right? You can set a volume, I can set a rate, I can mess with both of those to correct my respiratory acidosis. Pressure level, rate, and eye time are adjusted in a pressure controlled mode, assuming that it is a solely pressure controlled mode, or you have a rate set to begin with. The amount of increase or decrease is proportionate to the level of PaCO2, and that's what the formulas are about today. We're gonna learn how to specifically set something to achieve the outcome we're after, okay? And these are some that I use in the hospital to figure out where I wanna be. All right, so we have two techniques. You either increase or decrease the parameter that needs to be changed, and then you check the blood gas. So in other words, I walk into the room, I change something, I get a blood gas, I see if I fixed it or not. Or I make a change, I look at the monitor, I look at my saturation and my end tidal, and I see, am I in good shape, okay? The other way is to actually set a formula that is going to use the formula to tell me what I want to have set. And that is what we're going to talk about today. I should make Leah write this, she's writing this very fast.
I will if you want.
I should actually let you hear, come here. You write so much better than I would. I know, I never told you. So for this one, C is current, D is desired, and you can just write it all like that. They're all the very same thing, just for different parameters. Who wants a chocolate from the world? There's just got chocolate. Nothing. Mexican hot chocolate, seahorse praline truffles, seahorse, caramel praline, a cherry filling treasure chest, blueberry yogurt filling, coconut cream with salted caramel, milk caramel apple Peyton, Irish cream, hazelnut truffle balls. I say we need them. Alright, eat one. Eat one while we make Leah work. Irish cream one is good.
I just don't want that baby.
Irish cream one, the bomb. That was really good.
So a desired CO2, like,
So think about it as normal.
would it, okay, I was gonna say, would you
Yeah.
just shoot like a normal or? would you
Absolutely.
just
So
be
if,
like-
let's say your CO2 right now is 80, but I want it to be 40, I'm gonna throw the 40 to the desired. That was good. Which one did you get?
Caramel, salted caramel.
Ooh, my mom's gonna want those ones. Her favorite Starbucks is a salted caramel macchiato frappuccino thing. I can't order over there, I don't know. And I go, she goes, what size do you want? I'm like, medium. And she goes, it's okay, English is my first language too. I'm like, bitch. I don't know what to say, venti. I hate that place. I can't order coffee from those. They're obnoxious. I think she was trying to be nice to me, but it came out very condescending. I'm like, I don't. I'm already sassy, so don't mess with me.
I just can't tell if that's hot chocolate like drink or like spicy.
I don't know.
Because it's Mexican.
I don't know. Eat one and tell us.
Might be spicy.
Eat one and
I'm
see.
really curious.
I think you
It
should do
does
it.
feel right there.
I think you should do it, tell us what it's like. Good morning. you know like how they have a scribe at the hospital, yeah? I'm gonna hire you for that from now on. You can write all my stuff on the board. Well, I truly do have the worst handwriting in nature civilization, with the exception of a student I have in my other class. He cannot write at all.
I'd probably take that.
I think I just grew up in the generation of note writing.
Yeah.
And I wanted to be a teacher, so that was it.
Well, you know, if you get out into the universe and you work a couple of years, you do critical care, come back to it.
To work,
Here.
to work like little people.
Yeah.
Do you remember like your first grade teacher's handwriting? It
Yeah.
was perfect.
It was absolutely perfect.
That is weirdly good.
Yeah.
The Mexican one.
Is it hot? Like spicy hot or like hot chocolate?
Well, it's like spicy hot, but it's not like overpowering. I think it's like cinnamon hot.
We were in, my son and I were shopping last week before my world exploded again, and they had this special kind of Smirnoff vodka to try, which is sample, and it was hot. It had a bunch of spices and it was so weird. It was like, I don't know how I can't describe it, it was so weird. The bottle was really awesome. I'd have bought it just because the bottle was cool, but I wouldn't drink it, it's gross.
I've had a spicy margarita before.
Yeah?
I mean, it's
I
alright.
don't know what was in it, it was hot though.
Alright, guys.
Thank you for that.
That is a lot of equations.
But they are all very, very similar. Do you notice the pattern?
Yes.
Okay, so anytime you're looking for something to fix a respiratory acidosis, the formula is exactly the same. Have it, okay? You're gonna take what you have currently, times the CO2 that you have currently, and divide it by whatever you want the CO2 to be. So rate, tidal line, alveolar ventilation, all have the very same setup, okay? Irish cream on your bottom.
Which one?
Irish cream on
That's
your
what I got.
Mm-hmm, okay.
Oh, let's try the hot chocolate.
Yeah, which one's the hot chocolate one, remember? Let's just
What
drink
color?
chocolate all day.
What you guys doing today?
Well, you know, talking about kindergarten, the best day of your life was right before vacation. You didn't do anything but play and watch movies. What wrapper did that hot chocolate one have? I'm gonna give that to Leah.
Huh?
Which wrapper did the spicy chocolate one have?
This red one? It was kind of like it had a flat bottom. The cheat sheet is on the side. Did I get the only one?
That one. Oh, there it is. Right there. Oh, this one? Oh, one. There's two. No, hot and chocolate don't go together. You guys know more? I need more. I need this one.
Well, this is really cool, because I seriously thought we just like pulled numbers.
Well, you, and,
I mean, you do eventually, I know that, but like.
no, but I'm gonna tell you, a lot of therapists, who do you see standing at the bench and pressing buttons?
Yeah, but like, I mean, it's really cool that there is a way, like, if
Yeah.
you're really trying to target something specific.
And so we're gonna talk
Figure it
about
out.
this and, practice a couple of them, but they're very easy. So for your quiz, after you come back, you're gonna be able to have this on your release. So don't worry about trying to memorize all these, but you can see they're all the very same formula. It's just, what are you looking for? Okay, what's the parameter you're trying to find? And what do I wanna correct?
So the only part you change is just the very beginning.
Yeah, it's what am I looking for?
Okay.
So it's basically current times current divided by what you want. So it doesn't matter what parameter you're looking for, they're the same. Okay, and then the FiO2 is the PaO2 times the FiO2 that you have currently divided by the PaO2 that you have currently. So the first PaO2 is desired. So, Ms. Leah, the first PaO2 should say D for desired. So I'm taking what I want,
Desired?
yep,
And
that
then-
times the FiO2 that I have currently,
Okay.
divided by the PaO2 that I have currently. So that one's flipped just a little bit. Okay, but like I said, you're gonna get to have your Ruby with these, okay?
And then as far as the volume, you can still use that 6 to 8 in the.
Yeah, so I'm following Dr. O's instructions. That'll take you, we're gonna use 6 to 8 in here, okay? I just want you to be aware, if you're practicing, like say you buy a company's, another company's review, it may take you clear up to 10, and that's okay. You know, like I said, when I started off, we were ventilating people at 15 mLs per kilo, having all kinds of trauma, so yeah.
In the real world, when you're trying to find the initial volume, then you can just use that.
We actually do use at the hospital 6 to 8 right now because a lot of our people have COVID. So we really do, and in fact, if the x-ray's pretty whited out, they'll make us use 6 mLs per kilo for the COVID people. And we put a sticker on the vent with their ideal body weight and what that tidal volume should be, so that everybody who follows you and comes into that room knows what to pick. You guys are more chocolate, I'm serious to get by us the whole time. I thought of that hospital, I almost bought some. Yeah, okay. I'm just putting all that past the box down. If I take this home by myself, it's not gonna be a good situation. Oh, I did, hold on. Can't get it out of the package. I got it, look. It's really a seahorse. I was like afraid it was made with seahorse. I was really disturbed with seahorse. No food, a bunch of sugar. It's gonna be a good afternoon. Topped up. That
I
seahorse one
made
is
the
good.
best cookies. I almost brought you guys some. I should have brought some.
Yeah.
They're like the best ones I can make.
So anyway, so for rate, tidal volume, alveolar volume, and minute ventilation, all the same formula, okay? So it's not up there right now, but for minute ventilation, you can do the same thing you did for alveolar ventilation, same formula, okay? So it would be desired CE, VE, that's it, that's the change, okay?
So the other one is different, is the fire.
Yeah, and the pressure control one's a little bit different, but not by much.
Are you guys okay by erasing?
Thank you, Ms. Leo. No, seahorse is pretty good too, I'll tell you. Which one was that one?
Cherry treasure chest.
Ooh. Y'all be bouncing out of here at 5 o'clock like, "Ew."
This is really bad because Dr. K, I was here early.
Uh-huh.
And Dr. K saw me and she gave me some of her chocolate juice.
Is that what you did? I looked right at those at Costco, I'm telling you to go buy me another box.
I like the hot chocolate one.
Is that good?
Right? It's like weirdly good.
Different.
Because it's not, you can taste that it's spicy, but it's a cinnamon spice, so it isn't like, it's not like, I don't understand people who do like green chili and chocolate.
Yeah. I will tell you, once I had a green chili apple pie though, that sounded absolutely nauseating, but it was really good. It was good. I was like, this is so weird.
On the way to, I think it's Grant's.
Yeah.
There's a billboard for a green chili vanilla milkshake,
Oh.
and I want to try it so bad. It sounds horrible, but I want it.
Yeah, those are really good. Okay, let's just try one, guys, and keep the mouth work out for you. So we have a patient with a bunch of information. They're on a tidal volume of 600 already and a rate of 10. We have a gas that's not wonderful. Okay, so we have uncompensated respiratory acidosis with a little bit of a CO2 problem. I'm going to figure out two things. Where am I going to set the rate, and where am I going to set the volume? Okay, in order to achieve a PaCO2 of 40. So grab the other piece of pressure bill. Thank you.
Okay, so.
Thank you. So just take that formula. So we're going to do the one for rate and the one for tidal volume. So you would set it up. I need to go see my clicker's next door.
So
So I set up rate would go here. So what I have now would be, I would put in 10 times the PaCO2 I have now, which is 60. That's not good. Divided by what I want, and I'm going to try to achieve a PaCO2 of 40. So 10 times 60 divided by 40. Okay. When you do the math, let me know what you get. Yeah. So in order to make that happen, I need to increase their respiratory to 15. That's pretty simple, isn't it? It looks like a lot of busyness, but it's the very same formula. Current times current divided by desired. If you can remember that, you're going to be fine. So if we do the tidal volume one, get your tidal volume.
Just a question.
Yeah.
For the tidal volume, are we gonna be using that in a decimal form, or is that gonna be
Yeah,
just
should we,
600?
should we change it to meters?
I wouldn't, because what did you get when you did the math in the first place? Divided by 40. Because then you get 900,
That's right.
which makes sense,
Keep it in
right?
milliliters.
Yeah, keep it in milliliters. I mean, it doesn't matter, the key is you have to know your tidal volume is in mLs anyways, if you wanna reverse engineer it, that's okay. Okay, now, out of these two though, we really don't have a lot of information about our patient yet, so it's kind of nerve-wracking to take up the tidal volume per 900. Okay, that's a big jump. So in this case, which is probably the safer choice? Yeah, so I want you to put that in your mind too. That's safer than this, okay? If I don't have the exact tidal volume that I need to target for this patient, I don't have their height or whatever, for the board exam, you will be getting the person's height and probably a weight in kilos or pounds. You still have to think about your ideal body weight. Sometimes they give you somebody who is 5'7", but they weigh 400 pounds. Not very often, but sometimes, okay? So this is a safer choice for that, okay? But it's not hard, right? The first time I saw this formula, I'm like, this looks like Chinese. It's not. It's the same formula over and over again, with different choices. Okay, so now let's see what happens. We have somebody who has a different problem with their blood gas. What's going on with their blood gas now? Oh my gosh, a little chocolate. So name that blood gas.
Uncompensated respiratory oscillosis.
Perfection.
Moderate hypoxemia.
Okay. So let's do
Mild.
not mild hypoxemia, they're fine, right?
Noroxemia.
Norm, yeah. Normoxemia.
We
Which is
looked
80?
up the same one, yes. You might be on the wrong one.
No.
It's there.
It's like
You've got a different copy.
Stop smoking crack at lunch. So we're gonna do the very same thing we just did. So we wanna find the rate and we're gonna try to achieve our PaCO2 of 40. Now it should make sense to you that something's gonna have to be decreased in this case, right? I'm not gonna be turning stuff up. And also, the last one that said tidal volume of 900, that was not a product of the two. Like we didn't take 900 and add it to the 600 and put the tidal volume up over a liter. That's not what we do. It's what are we going to change it to?
We're replacing.
That's right. The class before you, because it was all online, they had the worst time understanding that. I'm like, what if I took a rate change of 15 and added it to the 10 I had, then I've got 25 now a minute, and that's not what I'm after. Okay, so try it again. And we'll try to figure out what a rate should be. So right now we have a rate of 20. Oops, what was that? Okay. So when you get it, let me know what you're getting. Just plug it into the same bubbles. For where rate? Yeah. Okay. Oh, I didn't do that one yet, I did the other one first. Okay.
So
Is that what you
13
mean?
Yeah, you're gonna round up, yep.
13.
Cause I can't give you a half a breath on vent. So what would you like to do for Title I? How many?
500.
500? Okay. That's what you guys got? Perfect. So in this case, I got a decrease, right? And I got a decrease to this. Now, which one of those is probably the best idea?
Tidal volume.
Yeah, because you could kind of assume that this is probably probably a lot for a person nowadays, okay? And the rate is at 20, so without the person's height and ideal body weight, you can't say 100% for sure. I just want you to be aware to look at, if you are given the opportunity to change both, which one is more appropriate, okay? And you're just gonna be looking for tidal volumes that are outside the range or going too low. So let's say this tidal volume was less than 6 mLs per kilo, I can't go down there, okay? Or if this rate change, because of the math, worked out to be a rate change going to a rate of 8, I can't do that either. So you're gonna get choices sometimes for the boards that don't make any sense, and you have to pick the other one. Does that make sense? Okay. But it's pretty easy, right? Not too bad for our last lecture before break. I have to think too hard. Okay, so same thing with the minute ventilation. And now she didn't put that one up there, but it's the same thing as this. Okay, so this would be,
So 3 times 60 divided by 40.
yep. Okay, so same formula. Okay. You do this one first, or should you do first again?
Minute 1.
Okay.
Hold on. No, that was alveolar ventilation.
Okay.
Yeah, that was alveolar ventilation, right?
They're the same formula, so it doesn't make any difference. Just putting the same numbers in there.
And there's 4 and minus 60.
So 4. For which one, Diego?
For the minute,
Okay. Okay. This is one you had for 4.5. Now we're gonna leave that at 4.5, because if I round up, that's a whole 500 extra mLs. Okay, so we don't wanna do that on this one, leave it how it lands, okay? So I can correct him both ways. So what is the safest one to do? Well, either one's appropriate. They're both right back in normal range, aren't they? Okay, so either one is fine. Now, if I have to increase the minute volume, I'm gonna go up on tidal volume first, rate second. Okay, same thing with alveolar ventilation. If I have to correct it, I'm gonna go up on tidal volume or up on respiratory rate second, depending on where I fall with my normals. All right.
And tell me the normal minute ventilation. again.
5 to 8 liters a minute. The key is that you take in more than you actually get to use. Just what kind of dishes, it doesn't want to come off. Okay, so you get the idea. If you want to keep working through, this is exactly what they are. I mean, it's the very same formula, it's over and over and over again. I'm either turning stuff up or I'm turning stuff down. If you want to try it, you can. You guys feel pretty good about it? Like I said, for the quiz app, you're going to get to bring your woobies. So make sure you get all this. And if you want to separate them, Brian, because you might have to see it up written out, make sure you write it this way with the whole thing. Okay. But the short version is, if I have a respiratory acidosis, I'm turning something up. If I have a respiratory alkalosis, I'm turning something down. That's it. Okay. Now, when you're dealing with a metabolic acidosis or a metabolic alkalosis, if that's your only problem, I correct it by simply giving KCl or giving bicarb. That's it. Okay. When you have mixed problems, if I have two things causing the same pH problem, okay, So I have a respiratory and a metabolic acidosis. I have to deal with both at the same time. That is the only time that I make two choices at once. Make sense? Respiratory alkalosis, I have to fix both of those. Okay, and remember with that, I still have to think about condition or what the cause is. So that's usually how I fix that, okay? If a patient has metabolic acidosis and they're left to their own devices, they start to get tachypnic in order to compensate, right? They blow down their CO2 on purpose as a way to try to straighten out thermal bicarb. Think about your diabetic ketoacidosis patients. If you've never seen one, that's exactly what they look like. They will breathe 70 times a minute, I'm not even kidding. And to the point to where they are at risk of going into ventilatory failure because their muscles can't keep up. It's just too much, okay? So we don't, on the board exam, increase rate, minute ventilation, tidal volume, or alveolar ventilation to fix a metabolic acidosis. We don't do it on the boards. Write it down from our big letters, okay? We do not, for the boards, increase minute ventilation or alveolar ventilation to deal with a metabolic acidosis.
One more time, please.
Yep. On the boards, you do not increase minute ventilation or alveolar ventilation as a way to correct a metabolic acidosis. That is the absolutely wrong move for your board exam. If you do that, you will miss the question. Okay. Now, here's the problem, and write this down. Real people, we do it all the time. You're gonna see people on jacked up rates. Who's come with me and seen patients set at 36, 34, something stupid, right? It's because they're trying to deal with this. At the hospital, for the NBRC, they give bicarb. They give it to everybody. They put it in people's hair. They give it to them to drink. It's everywhere. They don't have a problem with it. Hospitals in New Mexico don't just pass out bicarb like it's free. So that is why we purposely hyperventilate at Loveless to deal with this. But do not, I cannot repeat this enough, do not do that on the board exam. You will miss the questions every time. They are very specific about it. And they're also old school. Back in the day, we did give lots of bicarb to people. Problem is you can't ungive it. So once you have gone down that road, you can't ungive it, okay? Now, do I necessarily agree with that as a practitioner in this state? I don't, because I've had people with a bicarb of 6, 8, that they were reluctant to start bicarb on. I'm like, why? Why? They're dead. They're dying this moment. They're breathing 80 times a minute trying to keep up with that. And then by the time I find, at least in my hospital, by the time the doctors do want to deal with bicarb, I feel like it's too late. But for the board, we don't hyperventilate to fix it. You have to give bicarb. And I cannot say that enough. Okay?
So what's their protocol for that? Like if they were already hyperventilating, we set the rate high, what's the criteria to give bicarb?
Well, and that's why the boards say not to do that, because if you're breathing 50 times a minute, I can't overdrive you with that on the vent. There's no way. And being said, if you're breathing quick already, I am not going to be setting you with a really high rate because you're already doing it, okay? But the problem is, and the second side of that talks about when they poop out, okay? And you're gonna see people breathing crazy, spontaneously crazy, all of a sudden they're breathing 10. And it's because they gave up and their muscles can't do it anymore. And that's when we take over. Or if I paralyze you, I can breathe for you. Does that make sense? But if you're breathing 50 already, I will never overdrive you with the vent, which is why we don't intubate and ventilate for a metabolic acidosis, ever. Now, once they flip a respiratory component with that, in other words, they give up, can't breathe anymore, now they have a respiratory acidosis, well, now I get to tube you. Because I can deal with that. I can breathe for you after that. Does that make sense, guys? And as so far the protocol, I don't know if there is one at Loveless, to be honest with you, Diego, because I see every practitioner doing something just a little bit different. And I think half the time they run around talking to, little elves they have in their pockets. I don't know where they're getting this data. I really don't know.
So it just depends on what the doctor wants to do.
And I've seen one doctor goes in and just changes everything in the unit, takes off everyone's sedation until the nurses want to escort him. And then other people are like, oh no, you can't wake him up. Well, there has to be a balance between the two. We can't just In the ICU, there should never, ever, ever be blanket statements of you can never do this or you can always do this, because every person's different. And as you guys have seen already, COVID is its own nasty little beast. And it does whatever it wants. So what works on, Leah with COVID is not gonna work on Diego with COVID. It's not gonna work on Brian with COVID. I could try stuff that worked on Leah, and Garrett won't touch her. You just don't know.
I'm sorry, I was talking about.
That's okay.
My husband.
You're fine. Is that 2:30? I thought it was possible. Yeah. No worries. There is a video recorded for this if you want to go through it later. The math is the most important part.
I looked at it this morning, actually.
Yeah, this is not, like I said, for a lecture on your way out the door before break, this is a pretty decent one to get through. So, all right, girlie, there's no homework, by the way. I will get a study guide posted just to tell you what to work on for the quiz, but it's basically this stuff. So it's gonna be hazards and complications, that we talked about recently, what happens to the heart and stuff, and then this. But I'll get a study guide posted.
Cool, well, thank you so much. You guys have a great Christmas.
Have a Merry Christmas, take care.
You guys be careful getting it.
All right, now some causes of metabolic acidosis, they're up on the board. I want you to memorize these, okay? The boards are very, very keen to give you a history with one of these and not tell you that the patient's in a metabolic acidosis. They'll tell you they've had vomiting and diarrhea for 3 days. They'll tell you that they've been in a lactic acidosis. They'll tell you that you've had an ethylene glycol poisoning, okay? And if you go back to your other class, 240, when we talked about toxins, remember we talked about cute dimples and all those things that cause these metabolic acidosis, that kind of stuff, they will toss that to you every once in a while. So we treat the cause, and if we can't fix the cause, then we can give bicarb. On the boards, you always give bicarb, totally okay.
And the Diamox?
Diamox, yeah, Diamox helps people poop, and it helps get rid of bicarb. So if you have somebody who has a lot of issues, they can give them Diamox, and that'll help get rid of some of the bicarb if they're really high. But it also can send them over the other side. So you can see gases like this on your board that say you got somebody's on a vent. And remember, it doesn't matter what the history is. You have a human on a ventilator. That's it. We don't care. We don't care if it's a tiny human. We don't care if it's a young human. We don't care if it's an ancient human. We don't care. It's a human on a vent, okay? Everybody gets all sucked into the history part of it and what's happening without realizing, do I have something I need to fix? Okay? Because if I don't have anything I need to fix, it could be a sedation problem. Maybe it's a tube issue. It could be anything that's not related to you needing to fix the blood gas, okay? But they always give you this litany of crap that goes along with it that is not valuable, okay? You have to learn how to sort that out. So we have somebody who's on a vent, they've been to Kipnick, who cares? They have an ABG drawn, and the results are there. What do I want to do, okay? So, right now, first of all, do I have a problem with my blood gas?
Yes.
Okay, what do I want to do? What's my problem?
The bicarb is acidic.
Yeah, so I have what is it called?
Metabolic.
Metabolic acidosis, right? So first of all, if you get stupid crap like this, you have no data that the person's even intubated. You have no data they're on BiPAP. These are stupid. What am I do? Walk in and smother you with a pillow? Like, how do I make you do this? Right? Old school, they actually would give people a paper bag to breathe into and make them rebreathe their own CO2. So you see the old shows of somebody who's hyperventilating, and they would do that on purpose. But if I don't have any data that they're being vented, that's done. Okay? KCl, not helpful, because that actually eats this. So if I give that, I'm going to have a problem. I only have one choice. Okay? And you guys have been working on blood gases enough that I feel like you're pretty comfortable with this stuff. So metabolic alkalosis, again, these are some of the causes. So you want to make yourself familiar with some of the causes that you can have to deal with. So again, anytime you lose a lot of volume, whether it's from the stomach, the GI system, acid loss will cause you to have metabolic alkalosis. So if somebody's got a really bad GI bleed, they can wind up in a metabolic alkalosis, okay? I treat the cause, and if I can't, I give them potassium chloride. So again, you have a person on a vent doing something. Do I have a problem with my blood gas? What do you think?
Yes.
I do, right, have a problem with blood gas, but it's not a ventilation situation, okay? And again, I haven't been given any information to the patients even on a ventilator, so decreasing the rate or tidal volume is a waste of your time, so you don't know that you can do that. So in this case, I just have to give KCL. Does that make sense? Now, if I have two problems, I gotta fix both things. Okay, so your blood gas on the left, you have a mixed acidosis. The blood gas on your right is a mixed alkalosis. I have to treat both abnormalities. So with your mixed acidosis, I have to give bicarb and intubate and ventilate. If they were on a vent already, I would have to increase ventilation somehow. If I have a mixed alkalosis, I have to treat both. So I'm going to give KCL and find out why I have another problem, okay? So for that example on the board, my PaO2 of 70 is my problem. That is making me have a making me have a respiratory problem, right? I'm breathing too fast because the PaO2 is low. That's my cause. So find the cause.
So for that mixed alkalosis, you would intubate and ventilate and give KCL?
For mixed alkalosis, no. I would do something to improve oxygenation. So in this case, they're not on, we don't have any data, but we're gonna assume they're on Romero because it doesn't say, so I would just put them on the nose and give KCL, okay? So find the cause, and if I can fix it, correct it. Now, there are times, and we've talked about this before, where we deliberately blow down somebody's CO2. Pretty rare in the cases of head trauma, and we're trying to keep that PaCO2 between 25 and 30. That's the most important statement on this slide. Okay, know that value, know that range. We don't do this forever, but it can help decrease cerebral pressures. Remember last time we talked about that cerebral perfusing pressure? If you blow off somebody's CO2, it opens up the blood vessels in the head, which actually lowers that a little bit. Kind of controversial. I haven't worked trauma in a long time, so I don't know if that's something that's still done or not. You guys, when you get to UNM, can tell me if anybody still does that. So what's permissive hypercapnia? Well, sometimes, and this is happening an awful lot with COVID, the blood gases are just so bad that we have to just realize we can't push it any farther. I can't correct it without blowing up a lung or some other catastrophe. So we call that permissive hypercapnia, and it's where we're deliberately accepting that somebody's pH is going to be crap, so less than 7.25, in order to not damage the lungs farther. Because I can't take you past your 8 mLs of volume or past your rate of 50, right? I'm not going to breathe for 50 for you, so I can't do that. So there's a certain time frame when this is not going to get better, and I'm going to have to just understand I'm going to be dealing with permissive hypercapnia. So, we're doing it as a lung protective strategy. So we're just basically saying, okay, you win. I'm going to have this ugly pH, and I can't fix it anymore because I've maxed out on all my settings. That's permissive hypercapnia, okay? Which sounds like we want it. We don't. I kind of think it's more of a, I have no choice, and I just have to accept it. Because at some point I'm going to pop a lung, and that's what's happening with a lot of our COVID patients.
But what would, is it like giving up then at that point? Or?
Kind of, in a way. It's saying that your peak pressures on your vent are already really high, your plateaus are high, your mean airway pressures are too high. I can't make any further adjustments on the vent without hurting you further. That's what you're saying, okay? And it's really obnoxious because there's times when I'm like, man, I want to fix this and I can't. And that's been the hardest thing for me staffing still with COVID. Because I'm an old dog, I've been doing this a long time, I got lots of tricks. And there's times they don't work. And you want to change stuff, and the vet's doing it, and the patient's not responding. And it's just very frustrating. Because you're like, I should be able to correct this. I know a lot of stuff, I should be able to fix it, and you just can't. Yeah. Now, we don't allow for permissive hypercapnia from the board perspective in patients with head trauma. Okay. It's contraindicated in patients with cardiac instability as well, because it can cause arrhythmias and decrease myocardial contractility. And high CO2 may also affect regional blood flow to organs. So what happens in that case is because you become so acidotic, your body is not used to working in an acid environment, and lots of stuff goes down. So I don't like the term permissive because I feel like it's saying, yes, we want it and we're doing it on purpose. I look at this more as we have tried everything we can try, and I have to just now accept this is where we are or I'm gonna blow your lungs. Okay? Questions so far? You good? We're lucky. Something good. Somebody's repeat. You guys wanna take a short break?
I'm okay.
I'm good.
It's up to you.
Okay, then I'll put a little motion over there. Who have been in a possible fire and have airway burns, those are emergencies. Now, you can go into the bed and just turn stuff up, or I have a lovely formula for FiO2, which you took off the board now, but you have a picture of it, of how we can decide what we need it to be. So we can actually use this formula, which says what FiO2 do we want, and the formula for it is PaO2 desired, so you want to improve it to something over 80, right? Times the FiO2 they have currently, divided by the PaO2 that they have currently. So you're going to use that formula. So we have a patient being ventilated with a cerebral eye, volume controlled mode. The patient is on a 50% FiO2. I have pretty good blood gases except for the PO2, do you agree? Okay, so what FiO2 do I want to set the patient at to achieve a PO2 of 80? Okay, so once again, not as easier, but okay, just get it on the parameters. So if I want 80, currently, what I have is 2. Okay, so what'd you get? What am I gonna be turning the FiO2 up to?
80%.
Yep, 80%. Okay, and like I said, guys, you're gonna get to have your whoopee, so modify your whoopee over break so you can bring it with all the new stuff on it. And then for the board, we actually would confirm that with an actual blood gas or making sure that the oxygen level came up on saturation. We can use PEEP as well, which we talked about that to death. Now we have to have PEEP because we have to improve our contact between the alveolus and the circulatory bed, right? So more PEEP, take that little awful flattened alveolus and blows it up until it contacts the capillary bed again. Okay, so that's what it's for. We start off, it can be between 2 and 6 for the boards. And we talked about this in your last class. We also use things like CPAP for people besides obstructive sleep apnea, but we can use it for cases where somebody has congestive heart failure. And that will help push some of that fluid back across the AC membrane. So you can use PEEP for low lung compliance, refractory hypoxemia. When you have a PaO2 of less than 60 and your FiO2 is set at 60. When you have a poor PF ratio, which is where you take the person's PaO2 and divide it by their FiO2 as a decimal. Do you remember that formula? It's been around a while. Okay. I make sure that gets on your whoopee. And then also if you have bilateral fluffy infiltrates on your x-ray, which is another sign of CHF, right? So my mom, because she has a history of CHF as well, she does very well at night on her VPAP and her 4 liters lead-in. So she sats like 97 at night because she's got pressure on as well. But then in the morning when she moves, she drops and she has to hack up all those lung worms that were trapped in there all night. But hopefully they start to come up. So the level of PEEP that is appropriate and the best for the patient is something called optimal or optimum PEEP. It's also known as a PEEP study. And what you're doing is you're actually titrating up or down PEEP to see what the response is that you're getting from the patient. And we want to pick the level of PEEP that works the best and causes the least amount of complications. So our positive effects, of course, is increasing the functional residual capacity. That's the whole purpose. It helps increase compliance. It helps decrease the shunt. Helps increase oxygenation, and it helps increase the PaO2. That is all what we use PEEP for. Unfortunately, too much PEEP is also bad. And we talked about this a little bit last week when we talked about the complications that happen with mechanical ventilation. Too much pressure in the chest, and more specifically, too much PEEP decreases venous return, cardiac output, blood pressure. It's greater risk for barotrauma, and it also increases shunting and dead space. So once again, if my alveolus is really blown up, well then I haven't touched the capillaries at all. Now they're being really stretched out against this big ball instead of having a nice ball and nice comfy cushion of circulation, right? That's how it's supposed to be. So I have my little sad allostatic one, which is not touching. I used to blow it up, then have contact again. If I'm super blown up, then this is all stretched out and I don't have any contact. Does that make sense? So it's just as bad to have too much as it is not to have enough from a pulmonary capillary bed standpoint.
So, just a quick question. So what's the most PEEP that you've used
On a human,
on a human?
35, but it was a trauma, and we were allowed to do stuff like that. You know, he was a flail chest, and they wanted us to help stent that rib cage from the inside out by really overpressurizing the lungs. Now, he did not have any hemodynamic complications, and we were allowed to do so. Now, from a board perspective, they don't care how high you take the PEEP up. They'll let you do irrational things like take the PEEP to 35, with the understanding that once something bad happens, cardiac output declines, blood pressure falls, then I've gone too far. Okay, so it'll let you go as far as you want to with a PEEP study. Turn that bad boy up, but the second you start to have problems, you gotta turn it back down. Okay. Now this slide is really hard to see from here, because the color's bad and we have writing up there, I don't want to take it down yet. But the top says PEEP, and then the next one is compliance, the next is static compliance, the next one is PaO2, and the last one is blood pressure. So when you're looking at an optimal PEEP study, we've talked about this briefly before. I'm gonna look at the PEEP that I have set, and then I'm gonna look for anything over here that's bad, okay? So at a PEEP of 5, my blood pressure was high, PaO2 is 60, static compliance is 40. So remember with compliance, the higher the number, the better we are, okay? So I don't love that. Let's look at 8, okay? I got a compliance of 45, also not fabulous. PaO2 is getting better. Whoops, my blood pressure didn't like that. Fine, it's at 40 over, whatever it is, 40 over, oh, it's 85 over 40, it's backwards, sorry. PEEP of 12, I got a compliance of 50, PaO2 is 70, blood pressure looks pretty wonderful. 12 looks pretty good. Let's see what happens when I went to 15. I got a compliance of 70, well I like that. I got a PaO2 of 85, I really like that. My blood pressure tanked. So on your slide, fix this, it should be 85 over 40, they're backwards. Okay, that second one should be 85 over 40. You can't have a systolic higher than your or lower than your diastolic, that's not possible. Okay. So where it says 40 and 85, it should say 85 over 40. So we're looking at the PEEP that does the most good without causing any mischief. So in this case, it would be 12. Can you see that? And that's what a PEEP study is. I'm going to start playing with PEEP, and I'm going to look at these various parameters and see what happens. Now you can also see one like this in relation to resistance. You can see this in relation to hemodynamic parameters like your CVP and your cardiac output being compromised because of PEEP. You can see these in relationship to blood pressure and heart rate. Okay, so you can have a grid like this on the board with any measurable parameter that could be good or bad. And it's going to still want you to pick it out. But this version is a common one that you're going to see with the compliance of the PaO2. Okay? So contraindications of PEEP in general is an untreated tension pneumo. That in fact is a contraindication of all positive pressure until you get that chest tube in. Now, that's not to say that I'm not intubating you and putting in a chest tube at the same time, right? Because if you're dying, and I'm going to have to act all together. And in trauma, there's a huge team of people working on you, right? So it's not just one doctor, you got a whole fleet of people working around you. So contraindications of PEEP to untreated tension pneumo. People who are already hemodynamically unstable, I want to be careful with PEEP. And that's really the key for this today. I want you to take that away. So I can use something called the PF ratio to determine my level of ARDS, and we talked about this before as well. You guys remember the Berlin criteria or the North American European Consensus Conference? I always forget the acronym, I have to see it in my head. There are ranges that both of those standards have put forth to tell you how ardsy someone is, how much lung injury they've had. It's a very simple formula. You take the PaO2 divided by the FiO2, but it has to be as a decimal, so make sure you write that down. The FiO2 is a decimal in this case. Otherwise, you're going to get something very weird. Well, so what does that mean? Why do I care what the PF ratio is? So this is the North American European Consensus Conference. I think that's in my head a million times. That's that. Okay. This is what they said. They said if your PF ratio is above 400, you're fabulous. That's where you're supposed to live. They said starting to get around 200 to 300. Well, now you're in the state of being in acute lung injury. The lung has started to have some effects because of what you're doing. Once you got less than 200, you were in ARDS. Okay, that's how they defined it. Well, then a couple years later, the Berlin criteria got together, a whole different conference, and they said, well, we don't really call it acute lung injury or lung trauma and then ARDS. It's all ARDS to them. Okay. It's just what level. Okay. So less than 100 is severe. Okay? And that's what they said. They said, we're not going to call it acute lung injury, lung trauma, and then ARDS. It's all ARDS. It's all bad. We're doing horrible things to the lungs. But you notice that they said, gee, I'm really at a severe level when I get less than 100. Okay? So on the slide before this, you did the math for, you got 107 as your PF ratio. That's pretty bad. That's about a sneeze away from being really severe. Okay? So I hate to torture you with two scales, but the world talks about this now. The boards still mention this. So I don't know which one you're going to have to deal with. Just know the lower the number, the more sick and ardsy someone is. Make sense? So take a moment, write all that down if you don't have it. Okay, we good? So take notes. Yeah, let me know. I don't want them to take it. I don't think this is not real gold or anything. I don't know if they want it back. We'll just leave it on. Is that all right? Perfect. So if you want to do one just for fun, do the top one and see if you can get the math to work out. So very simple. You're going to take the PaO2, which is 80, divided by 0.8. You don't even need your calculator for that, I bet.
100?
Yeah, that's pretty crappy, right? But let's do, if you had a PO2 of 98 and an FiO2 of 30, what is your ratio then?
Grade 26.
Yeah.
Grade 27.
So the way to think about this, guys, especially for your boards, if these formulas just get all jumbled up in your head, the more close to room air and the higher PO2 you have, you're going to be up over 300. Okay? If I have somebody on a whole bunch of oxygen, I'm going to be somewhere low because it's the oxygen that makes all the difference. Okay? So if you forget how to work the formula, you can always take that. Now we also have another comparison we can do, which is looking at the comparison of the amount of oxygen in arterial blood to that at the alveolar level. Okay? And we can use it to evaluate oxygenation. And it's really related to a diffusing capacity. So if you're getting oxygen at the alveolar level, is it actually making it across into the bloodstream? That's what we're looking at, okay? Normal is about 1, and if you have a decreased diffusion, which is less than 0.8, that's telling you what's happening. So it's very simple. You just take your PaO2 after blood gas, divided by your P big AO2, your alveolar air equation that you did, okay? I don't use this in my practice. I've never used this as an equation. I don't know if somebody may have us doing it, I don't know. But it is something the boards talk about, so we're going to put it in our formula pile. So yeah, so little AO2 divided by P big AO2 is just another formula I want to make sure you have down, okay? Now we've talked about arterial oxygen content before, which is our C little AO2. And that's the total amount of oxygen that we carry in our arterial blood. It is the best index of tissue oxygenation. And normal is 17 to 20 volumes percent. On your Whoopie, you should already have this formula somewhere in your possession, do you? Okay, we've already talked about CaO2, CvO2, and AvDiff. Okay, so it's here again because it's part of this topic, but you should already have them. So very simply, this first piece of these formulas, hemoglobin times 1.34 times the saturation. This is as a decimal. Don't forget that this is as a decimal. This is what the hemoglobin carries. Okay? This, PaO2, not as a decimal, times 0.003 is what's carried in the plasma. And it's uselessly little. Okay? For my class and Dr. O's class, you're going to have to know the whole formula. But from a board perspective, if you could just get to this front part, you probably can get an answer close enough to find it. Because this is going to be 17 something. This is going to be 0.21. Doesn't really add a lot to this, okay? So from a board perspective, if the math is just not your jam, and you get this, you can do the front half, Brian, and get to the answer, okay? So again, another thing I want you guys to be aware of and write this down somewhere, the boards expect that you know what normal hemoglobin is, okay, which is somewhere around 15 depending on your book. This is what the hemoglobin can carry, saturation, normal saturation, that's as a decimal. You have to know this factor and that factor, that you have to know these are just part of that equation. They're not going to give them to you, okay?
So the 0.003.
You have to know that, yep.
That's what it can carry?
That's what was carried in the plasma. That's how that factor that's carried in the plasma. So the 1.34 and the 0.003, you have to just know that. All right, you'll be given the hemoglobin, the sat, and the PaO2. The saturation is used as a decimal, so make sure you write that down. You're doing something very odd if you don't. Now remember, if normal is 17 to 20 volume percent, if I get 200, I did something wrong. Okay? So with all this math, if you know what the normals are, you can't mess up because you'll know you're out of range or not. I'm going to give you one more hack. So my hemoglobin is normal, my saturation is normal, the PaO2 is normal. I have to be somewhere between 17 and 20 volumes percent. Normal and normal is normal. Okay? If they're all low, low and low is low. So if I'm all low, I have to be less than 17. So again, if you forget the math, you can actually hack that and just say, well, gee, the hematocrit, the hemoglobin's low, saturation is low, the PaO2 is low. I have to be less than 17. So pick the answer that's less than 17. Okay? Another hack. Its neighbor, venous oxygen content, which is CvO2, we've had this before, is the total amount of oxygen in the venous blood, and normal is 14 to 16 volumes percent. The formula for it is exactly what you just saw, except for instead of the SaO2, we're using the SvO2. That comes off of your Swan-Ganz catheter, your pulmonary artery catheter. The PVO2 comes off of your blood draws, a venous gas, and you also use the same 0.003. So I'm looking at oxygen on the arterial side of the body, I'm looking at it on the venous side of the body, and I need to look at the difference. Okay, so this is what we call the AV diff. And you're going to very simply subtract the venous CVO2 that you just got from the CaO2 you just got, and normal is 4 to 6 volume percent. Well, why do we give a good darn? Well, we're saying if I'm putting oxygen into the body, it should be offloaded and used by the tissues, right? Which means the venous side should be less. If your AV dip is more than 6, because normal is 4 to 6 volumes percent, that's actually very important to us. And it tells us that the cardiac output is actually decreasing. You need to highlight that statement, it's huge. Okay? If your AV diff is more than 6, your cardiac output is actually decreasing. Because what's happening is I'm not perfusing the tissues to offload it. Okay, does that make sense? So if cardiac output is not adequate, I'm not pushing the blood to the tissue level where it can be used. That's why you have a high number, which throws people off because you're thinking, well, if it's low, it should be low. No, if the AV diff is high, higher than 6, that tells your cardiac output is decreasing. So write that down somewhere. AV diff more than 6, cardiac output decreasing. And that is no bueno. So last week we talked about complications that happen from positive pressure. So once we hit that crisis of putting too much pressure inside someone's chest, it can manifest itself in having a high AV diff, which is a reverse engineered way the boards want you to think of, oh, my cardiac output sucks. Okay, make sense? But they're not going to tell you the cardiac output sucks. They're going to say your AV diff is 10. You're going to have to learn to make the connection, okay? Another oxygen indice that we can look at is something called the oxygenation index. Again, these are all formulas you want on your Ruby for your quiz when you come back. Okay? So the oxygen index looks at the relationship between the PF ratio and the mean airway pressure. And it's very simple. It's the FiO2 as a decimal times your mean airway pressure divided by the PO2, and you're going to get a percentage, and you multiply it by 100. So generally, a healthy person has an oxygen index of less than 5. If it's between 10 and 20, it's starting to tell you that the patient has impaired oxygenation abilities. If it's more than 25, it's associated with poor outcomes. The higher the oxygen index in relationship to a neonate, a new baby, high, if we're getting into 40, for example, they get to go on ECMO. And that's a reason that neonates get ECMO, because of high oxygen index. Okay? ECMO is basically dialysis for your heart and lungs. So we take all the blood out, it's scrubbed, it's given oxygen, and it's put back in the body. Very, very dangerous. So the higher the oxygen index, that's not a good thing, indicates need for ECMO. ECMO is ECMO. Oh, that was it. Sorry. Okay, any questions about any of that? Most of this is just formulas.